So they exclude many of the patients for which antibiotic efficacy is critical. So some studies, if you're in shock, you can't be enrolled. If you have a high Apache score, you can't be enrolled. The obvious one is immunocompromised patients are excluded from almost all of them. And we have a real problem with prior antibiotic therapy or even short-term prior antibiotic therapy prevents you from getting into a trial in which that therapy is obviously failing because you're still concerned about that patient. And the flip side is they include a bunch of patients in whom antibiotic efficacy is unlikely to change the outcome. So part of this is they don't know that the patient really even has pneumonia. So antibiotics are probably not going to help heart failure. And lots of tracheal colonization by using inadequate diagnostic specimens, and almost all of them have a huge proportion that are culture negative. How can you assess antibiotic efficacy when you have no bacteria to try your antibiotic on? So there are other problems. The reliance on mortality as the primary endpoint contributes to this overestimation of efficacy. So the attributable mortality of VAP is actually unclear. So antibiotics don't cure heart failure, they don't cure cancer. And so if you've got somebody with HAP-VAP and they have, you know, a widely metastatic cancer that got them on the ventilator in the first place, antibiotics are not going to change their mortality. In that setting, successful antibiotic therapy doesn't prevent death, it just turns them back to the same baseline mortality that they had before, whereas I think we miss this, unsuccessful treatment adds to the baseline. So I think that there is attributable mortality if you do it wrong, but you're going to have death even when you do it right. And we've got problems with the comparator drugs. Sometimes it's an inferior comparator. Sometimes it's inadequate PK/PD, so lower doses, not continuous infusions. And we have an issue that MIC breakpoints are changing over time. So there's soon come out that drugs that we think work for certain types of pneumonia are going to have to change. So basically quinolones for stenotrophomonas are just going to disappear because the CLSI breakpoints are going to change and they're all resistant. And so what you really need is superiority trials, but that's impossible with a mortality primary endpoint. So the flip side, so I just trashed the FDA, now I'm going to trash the EMA, which uses clinical response as a primary endpoint. And that's also unreliable. So the one bit of preliminary data that I have here is from our SCRIPT study where we adjudicate outcomes in our pneumonia cases as part of this study. And we started by having 2 people adjudicate using very strict criteria. And what we found is that there was only 60% agreement between 2 pulmonary critical care people looking at the same chart with all the data in front of you, all the cultures, in fact, more cultures than most people have. And it improved to 85% with the 3rd reviewer to break the tie, but sometimes the 3rd reviewer didn't agree with either of them. And so we had to take it to committee to get some consensus on this. Now, the flip side is when you say success and get 2 people to agree that there is success, it is highly reproducible, it is highly correlated with outcomes, and is very reliable. So in some ways, saying it's a cure using strict criteria has value, but not cure and indeterminate, and indeterminate is a particular issue. It's equivalent to failure. So this has been submitted and hopefully will be published soon. And so that's with people focused on outcomes and at least 2 people. The FDA and EMA registration trials only require 1 investigator to say, this is a clinical cure, this is not. And so it's got real problems. So I think clinical response is also inadequate. So our proposal is to actually go back to what I think we should have been doing for a long time, and that is to look at bacterial clearance. We're using antibiotics, they should kill bacteria. If you don't kill bacteria, they probably are not working. And so we're gonna do this with BAL. So we're looking at the alveolar site and do serial BALs to establish that the bacteria are disappearing from the site of infection, as well as that the host response is being damped down and changing. And so we plan to do for sure a day 7, 8, or when they plan to stop antibiotics, and also in a separate aim, a day 3 BAL. Now, the inclusion criteria is mechanically ventilated adults, clinically suspected hospital-acquired bacterial pneumonia requiring intubation, so the VHAP patients or ventilated bacterial pneumonia, and then documented bacterial pneumonia by quantitative culture of BAL or a positive biofire pneumonia panel from a high-quality BAL. And this has become an issue for us because we hang our hats on BAL, but not all BALs are the same. So what gets sent down to our micro lab from the thoracic surgery service doing what they call a BAL, which is splashing in 10 cc's of saline and sucking it back out, is totally different than a formal BAL with discarding the initial aliquot and 120 mils minimum volume that you put in. So we'll be assessing for high quality, both by volume and by cellular content. And then obviously consent from the patient. Now in order to provide real world evidence, we're gonna have very limited exclusion criteria. So we're gonna exclude all you bronchiectasis people because it's unclear whether you got pneumonia or an exacerbation, and a lot of our inflammatory markers probably are up in an exacerbation of bronchiectasis. So we don't, and there's a high airway load, so we may have false positives, especially of our PCR. We deal with interventional pulmonary, so we have airway stents in a bunch of our patients, and then obviously lung transplant during the acute hospitalization, where you still have problems with the suture line and altered mucociliary clearance, and frankly, transplant physicians are crazy, so they wouldn't listen to anything. All right, they're not in real world anyhow. So feasibility and statistical power, we had 565 patients who had a positive BAL in the last year. In all of our units, some patients had multiple episodes, so we have a potential of 400 to 500 eligible patients. We are assuming a 40% consent rate for end of therapy BALs, probably lower than that for the day 3, so we're going to disconnect them. And that's 150 to 200 patients a year, and this is a 3-year funding. So we may have up to 600 patients. Just as a reality check, so in script, we know that 46 patients had at least 1 repeat BAL as part of their usual care. So this 40% estimate of being able to get a repeat BAL, all of those standard of care will include, but we think that we should be able to get a 40% of those patients. And so we are also going to look at bugs separately and drugs separately. So with that, we expect to be able to analyze 6 priority pathogens. So Pseudomonas acinetobacter, MRSA, MSSA, a somewhat generic Enterobacteriaceae, and 7 priority drugs, which include 5 beta-lactams, which I think is the critical thing for HAPVAP. And not including the new expensive ones, so the cefapemes and piptazos. So I mentioned we have a sub-aim of correlating early microbiologic response at day 3 with subsequent clinical and microbiologic outcomes. So we're looking at a trajectory of is the bacteria disappearing by day 3, and will that carry through to day 7, day 8? And part of the reason we said this is early antibiotic response is used in other infections where clinical endpoints tend to merge over time. So urinary tract infections, skin and soft tissue infections, they ultimately all get better. And so if you're looking at a 28-day outcome in any of those kind of cases, or even a 14-day outcome when they all tend to get better on their own, so they've gone to early response or early clinical points. So skin and soft tissue infections have criteria for early clinical response. And then forever, we've been doing early microbiologic response in primary bacteremia and endocarditis. So the idea of early microbiologic response has some precedent. We hope this will lead to clinical trials subsequently. So early detection of microbiologic failure may allow early salvage therapy. So you can randomize patients to changing your antibiotics if you're not seeing clearance by day 3. In the flip side is if you see clearance at day 3, why not shorten antibiotics? I mean, why do we need to treat for 7 days? If God would have took 5 days, we would treat for 5 days or 10 days. If he would have taken 9 days, it would be 9 or 18. So there's no good rationale for 7 days, 14 days, 10 days, whatever you want to do. And so you can individualize therapy there. Now, we also know that everybody's not going to be doing serial BALs when we're done with this study for real world efficacy. So we're going to be looking both at a very complex clinical phenotype and changing over time as one strategy, or a set of biomarkers as an alternative strategy that now you can correlate with actual microbiologic response. So the problem with procalcitonin studies, CRP, any of these, is that if you don't know the ground truth, how can you correlate with that? And so for procalcitonin, you see a pretty nice correlation with improvement until you get down to about 20% of patients where it just stays elevated. And if you continue antibiotics, it's going to be elevated for 20, 30 days. Now, these early BALs will all be obtained while the patient is on antibiotics. So that's likely to suppress growth. So we expect that cultures may be negative at day 3. And so we're doing PCR and we're going to use the BioFire pneumonia panel, but we're also going to do metagenomic sequencing to see if we can actually pick up even smaller amounts, and probably more importantly, to assess what's really going on in the microbiome from day 0 to day 3 to day 7, with hopes that maybe stopping antibiotics earlier may actually change that as well. So that's my presentation. I have some issues for feedback. What's the value of this day 3 response? Is it good to include PCR positive only cases at the front end, so we'll have no MIC on them? We probably will be able to get beta-lactam levels on all of these patients, but if you don't have an MIC, you can't do target attainment kind of things. And frankly, our MICs are almost as bad as the culture results. So we keep changing MICs because we find out that if you treat a patient with some borderline MIC that they fail. So, we're talking about, the old CAP guidelines where 4 guys sitting around drinking beer saying, well, okay, what's important in this guideline? So that's, for the CLSI, it's a mixed group of 5 who are sitting around drinking beer and saying, okay, I think we ought to lower this MIC and this. And the other thing is we're not going to exclude anybody. So that's going to include patients who have some changes in their therapy. We'll have combination. So we may actually have some of us still use combination therapy up front, so we may be able to assess, at least get an early idea about that. So I think that's all I have. I'm happy to answer questions.
Very good. Okay. Then this is any comments or yes, Mike.
So Rich, that's a really great idea. And I think there's a lot to be said for what you're doing. A couple of questions though. There are different ways of failing in pneumonia therapy. You could fail because you just don't respond, or you could fail because you relapse later. And so this is clearly not going to detect that latter kind of failure, because you're not going to be scoping these people 3 or 4 days after they're off antibiotics, probably. And I guess that's the main concern that I have, is that even, in other words, I think it's really bad if you keep growing bacteria in spite of antibiotics. But if you don't grow bacteria on antibiotics, I don't know if that means you'll never grow or that you're really cured. And I think that's the assumption.
Yeah. So just for clarity, that day 3 will be on antibiotics. The last day, day 7, 8 will. So if somebody's committed to more than 7 or 8 days, we'll do it at 7 or 8, but we'll try to get consent for day 7 or 8. But the study is actually the day after they finish antibiotics. So they will be
But you'd
off.
ideally like it even longer than that if you could. I mean, another.
So, and they can recycle back in. So, you know, recurrence will be treated as a new episode and probably be treated with different antibiotics. But we also, so we have the advantage of doing this in the setting of our script study. So we'll have sequencing of the bacteria to tell us if this is even the same bacteria that are coming back or a new bacteria. So Jordy has some Pseudomonas that half the quote recurrences are actually a new. And so, but you're right. There's reasons to fail. We can't analyze why. You know, so.
And the other part, you know, I guess the other downside of not having any kind of MIC data is you won't be able to look at the PK. In other words, patients who got the right drug at the wrong doses or so forth, you're not going to have any of that to understand the failures.
So we'll be able to get. So we've got another study that actually is funded to do beta-lactam levels. So we will have serum PK and we'll have BAL levels on those day 3 if we get them in the.
So you're going to get it in this study as well.
Yeah.
Well, then that'll be good. Yeah, that'll be great.
We won't have an MIC to do the formal stuff, but we will have PK/PD. Mark?
So I'm sure you've thought about this, but you didn't mention it, but I'd be very interested in your thoughts. You're skilled critical care docs. So I'm going to assume that for the most part, you're going to be giving the right empiric antibiotics at the right dose in the right way. So if that assumption is usually correct, does a failure of clearance of the bacteria tell you more about the antibiotic or more about the host?
That, once again, we're taking advantage of having the script study. So we will be looking at the host. So, I mean, it's just kind of a 3-legged stool. You have to look at, are your antibiotics right? Are your host right? Or is it something really nasty about the bug? And so we'll have all of that somewhat addressed. And we have some of this data in script already. Like I said, we've got 35 who had serial BAL during the initial course of treatment. And part of what's driving this is when we're doing these evaluations, man, if you had a BAL culture that was negative at day 5 or 7, number one, the clinician is starting to say, well, maybe there's something else going on. Let's see about their gallbladder. Or let's take that central line. But it's, you know, I think this would, the problem with script is almost all of these are standard of care BALs. And so they're done at irregular times and with different thresholds of who gets a repeat BAL. So I have a very low threshold. If you've got a Pseudomonas, I assume they're going to fail. And I want to know that sooner. That's not necessarily the same perspective of some of my partners. So this just standardizes it. Yeah.
I want to know your thought about that immunocompromised patient that's going to be enrolled. Maybe they are not going to have response enough to biomarkers, and how you want to compare biomarkers in immunocompromised with normal healthy people.
Yeah. So great question. Huge. But what I'm saying with this study is until we know whether the bacteria have cleared or not, we don't even know where to start on trying to analyze them. So, you know, there are neutropenic patients and there are neutropenia does not mean you don't have neutrophils in your lung. Getting rituximab makes a huge difference in some of your host response, you know, so and this is the pilot study. This is the first study. So we expect that there will be multiple kinds of things and we'll do multivariate analysis, but until we know whether you've actually cleared the bacteria or not, I mean, immunocompromised patients, it's arbitrary 14 days because they're immunocompromised. Well, days. Right. So I think this study will actually generate more questions than it answers, but at least it gives us a starting point to look at some of those.
It's a question.
Yeah, thanks, Rich. Interesting study. I would love to know the results. So, my question is, when you follow for clearance, do you equate culture growth with quantitative biofire and PCR? How do you do that? You know?
Yeah. So to truly call it a cure, we're going to say culture negative, biofire negative. Metagenomic sequencing, maybe you still can have some pseudomonas there, and we're not going to call that failure, at least for our analysis standpoint. That's more trying to understand why there is failure and kind of what you leave behind when you get cure. So it's a little bit more exploratory.
So it sounds like you have a harsher. The assumption is you want to clear the whole thing, right? Because it could be that they might be colonization at one point that they're not going to go away.
So this is the one thing that I mean, it drives me crazy when I have people say, well, this is just colonization. And I say, but colonization means that they're there and they become one with the universe, and you know, the body's not reacting to it. I've got 95% neutrophils in my lavage. Right. That's not colonization. Right. It's also not tracheal colonization when I've got neutrophils and macrophages. Right. So, you know, frankly, I think this idea of colonization has been because we don't want to recognize how bad our antibiotics are. Right. And we don't want to use the expensive ones because the cheap ones failed. Right.